This is an introductory video, part of an interactive course designed to teach you how to read MRI of the pelvis in females. By interactive, I mean that you'll be able to scroll through full MRI pelvis cases representative of the most important pathologies and learn everything that you need to know about each pathology. This includes walkthroughs of the most important MRI findings and MRI pearls. The structure of this course is as follows. This first video will cover some necessary introductory material, including typical sequences in a routine MRI pelvis protocol, normal organ signal intensity, and how to characterize abnormal tissue that you'll commonly encounter on MRI. Then we have a series of carefully selected cases that you can scroll through and try to figure out as unknowns. For example, this is one of our cases here with all of the MRI sequences here on the left. Each case comes with answers and explanations. If you click on the blue square here in the top right, you'll see a walkthrough of imaging findings with links to key imaging findings. There is also an explanation of the pathology and some key learning points. So for example, in this case of bilateral dermoids, we talk about related pathologies that you need to know and the basic MRI principle of how to identify and characterize fat on MRI, including differentiating bulk fat from intravoxal fat. For Gyne MRI, the cases will focus on a few key areas: characterizing adnexal masses, staging malignancies, and uterine anomalies. There are also a series of more challenging and interesting cases at the end. By the end of the course, you'll have seen the most important pathologies that you need to know. These cases are available as part of our body MRI course. This will eventually include other sections, including hepatobiliary, pancreas, GU, and rectal sections. Before taking this course, you should already know some basic anatomy and some MRI basics. If MRI is new to you, I suggest you start with our Introduction to Body MRI video. Okay, so let's get started with the basics so we can get you scrolling through an MRI pelvis as soon as possible. In this video, again, we'll cover the common indications for pelvic MRI, aka why we do it. We'll go through the sequences that make up a standard routine MRI pelvis protocol. We'll show you what normal gynecologic organs look like on MRI with a focus on the normal signal intensity. And then last, some key principles that you need to know to characterize commonly seen tissues like fluid, fat, blood, mucin, fibrotic tissue, and what malignancies most commonly look like. If you can characterize the tissue and you know the pathologies that you're looking for from our MRI course, you'll be able to interpret pelvic MRI effectively. So, what are the most common indications for pelvic MRI? 1. Characterizing Adnexal/Ovarian lesions. Ultrasound is usually performed first, but MRI is used for problem solving. 2. Assessing uterine abnormalities, including fibroids and adenomyosis. 3. Assessing for and mapping endometriosis. 4. Identifying, staging, and restaging malignancies like endometrial and cervical cancer, which directly affects management. And 5. Characterizing congenital uterine anomalies. Ultrasound is also first line for this, but MRI is used for problem solving. Again, the MRI cases in our course cover each of these topics. Okay, so let's open up an MRI of the pelvis together. This is a normal pelvic MRI. To follow along and scroll through this case, use the QR code on the screen to open up the case on your phone, or use the link in the description. On the left here, we have all of the MRI sequences that are a part of this routine MRI protocol. So scrolling through and looking through all of these sequences here, it can be a bit overwhelming at first, but if we break it down, it's actually not that bad. So there are 4 groups that we can put each of these sequences in. The first group we'll talk about are the T2 weighted sequences. So this is an axial T2 weighted sequence here. Notice that fluid like the CSF here is very bright. Fluid in the bladder or the urine in the bladder is also very bright. And so for routine pelvic imaging, these are often performed without fat saturation. So notice that the fat is very bright to better define the anatomy. It's also usually performed in at least 2 planes, but here we have all 3. We have axial, sagittal, and coronal T2 weighted images. These are turbo spin echo or fast spin echo sequences, hence the TSE here. But regardless, that's our first bucket, the T2 weighted sequences in multiple planes. So again here, the axial, sagittal, and coronal T2 weighted images. Scrolling down here, second, we have the T1 weighted sequences. We cover these in detail in the body MRI introductory course, but as a reminder, we perform the in and out of phase acquisition first. So here we have the T1 in phase of the pelvis and the out of phase here with the India ink artifact. And then from the in and out of phase using the Dixon method, we can calculate the water only and fat only images. The water only image here is a nice T1 fat sat. Notice that the fat is very well suppressed here. This is a very important sequence in Gyne pelvis MRI since things that are T1 hyperintense or high signal on T1 will really stand out nicely here. The fat only image here will show both bulk and intravoxal fat. This sequence is also very helpful to quickly identify any fat in tumors and to look at the bones. So notice that there is normally fatty marrow in the bones here. And so any marrow replacing lesion is going to show up as dark on that bright background. Okay, so far we've talked about our T2 weighted sequences and our T1 weighted sequences with the in and out of phase and downstream sequences. Third, not in order of acquisition, but to logically remember all of the sequences, is your T1 pre and post gadolinium images, which again is logical. We're going to be giving gadolinium in contrast, so we have pre and post gadolinium acquisitions. In pelvic MRI, these are generally acquired as dynamic post-contrast series, either in the sagittal or axial plane. So here we have a sagittal T1 pre-contrast image. It's a T1. You can see that the fluid here is dark in the bladder or hypointense in the bladder. And you'll notice that it's fat saturated clearly here as well. And then gadolinium is given, and there are dynamic contrast enhanced sequences acquired. So here is an early post-contrast acquisition and then subsequently acquired images. Then we also do a delayed post-contrast acquisition in the axial plane here. Notice that these post-gadolinium images are fat saturated. In MRI, signal intensity is all relative. So if we want the gadolinium to stand out, which is very T1 hyperintense, we want to suppress the very high signal fat so we can actually see what structures are enhancing. Okay, and lastly, fourth, we have our diffusion weighted images, which again, we covered in detail in our introductory body MRI video, but this includes the DWI acquisitions with multiple B values. So here is a lower B value acquisition, AKA there's less diffusion weighting. It almost looks like a T2 fat sat or poor man's T2. Notice that the urine or fluid is bright. If we keep scrolling here, we get to the higher B value acquisitions, which are more diffusion weighted. And then calculated from that, we have our ADC. Things that restrict diffusion should be bright on diffusion-weighted images and dark on ADC. Again, this was covered in our body MRI intro video. So to summarize all of these sequences, it's really not as complex as it may look at first. Again, a typical routine pelvic MRI protocol includes our T2 weighted sequences in multiple planes, our T1 in and out of phase with calculated fat-only and water-only images downstream, our pre and post contrast T1 weighted images, and diffusion weighted images. Okay, so now that you know what all of these sequences are, let's look at the images and review what normal looks like on MRI with a focus on signal intensity. I'm not going to be reviewing the basic normal anatomy covered in the CT abdomen and pelvis video. So first, to orient you on this axial T2 weighted sequence, we have the bladder anteriorly here, clearly with T2 hypointense muscular wall. We have the rectum here posteriorly with the muscular layer also T2 hypointense. And then in the middle, or between the two, we have our gynecologic organs here that we're going to cover in more detail. Let's start with the uterus. So this is a T1 pre-contrast image. The normal uterus is pretty homogeneously hypointense on T1 weighted images. Notice that the uterus, cervix, vagina are all pretty homogeneously hypointense on T1 pre-contrast imaging. In contrast, for the uterus on T2 weighted imaging, we can see the zonal anatomy very, very well in the uterus. So notice here we have the endometrial stripe, which is very hyperintense here. We have the myometrium that is intermediate signal more peripherally here. And then more centrally in the myometrium, we have what is called the junctional zone, which refers to the rim of myometrium surrounding the endometrial cavity. The junctional zone is still myometrium, just more packed muscle cells that stand out here nicely on MRI. So normally this junctional zone is pretty thin. If it's over 12 millimeters in thickness, it's abnormal and indicates adenomyosis, but we'll talk about that a little bit more later. Next, we have the cervix here, and the cervix is a little bit lower signal than the myometrium and similar in signal and contiguous with the junctional zone here. On the axial images, notice how dark the cervix is on T2 weighted imaging. This is going to be important later because, as you'll see, tumor will not be as dark. As I scroll up here in the cervix, we have the internal os and the external os, which sits in the vagina. On post-contrast images, notice that normally the myometrium enhances pretty avidly, as you can see here. Next, the vagina, which also has a muscular wall, so also very T2 hypointense here. Notice on the sagittal images, so this is vagina here, that the lower cervix sits in the vagina, and this here is the posterior fornix. You can really follow the normal T2 dark signal of the vagina nicely here. Next, the ovaries. So on T1 weighted imaging, the ovaries are pretty homogeneously hypointense, as you can see here. But we'll focus on the T2 weighted imaging. So here is the left ovary, and here is the right ovary. So for premenopausal patients on T2 weighted imaging, the cortex or periphery is often slightly lower signal than the medulla or more central area, which is a little bit brighter. But the cortex contains follicles that appear as small fluid intensity or cystic lesions. These are physiologic, they are normal. One important skill on MRI is the ability to identify the normal ovary on MRI. And this is because you want to, of course, assess the ovaries, but also if there's a big mass in the pelvis and you don't know where it's coming from, the first thing you want to know is it coming from the ovary or something else? If you can identify normal ovary separate from the mass, then you know it's not coming from the ovary itself. Identifying the ovaries is easy in premenopausal patients on T2 weighted imaging. They're often going to stand out very well on T2 weighted imaging because of the follicles. So you'll see this classic appearance with multiple bright follicles, which again are normal. But if you can't find them, or it's a postmenopausal patient without any or many follicles, there are a couple of things that you can do to identify the ovary. So first is to follow the ovarian vessels in the suspensory ligament. So here they are here on T2 weighted imaging, and they go directly into the ovary inferiorly here. They're probably more easily identifiable on the post-gadolinium images. So here we have the ovarian vasculature, the artery obviously arising directly from the aorta. If I follow that down, it dives directly into the normal right ovary. If you still can't find them, you should look for, again, the suspensory ligament itself with the ovarian vasculature in it, the round ligament as well. So the round ligament is here, this T2 hypointense structure that extends from the uterus and through into the inguinal canal. Here it is on the left. And the ovarian ligament, which extends between the uterus and the ovary itself. So that's it here. And at the junction of all three, you should generally find the ovary. Okay, so regarding what normal and abnormal is when it comes to the ovary, you need to remember that in premenopausal patients, with every cycle, the following will happen. So you'll have follicles in the ovary early in the cycle, like we're seeing here, and then you get a dominant follicle that will look like a larger simple cystic lesion, which is normal. That's why if you see a simple cystic lesion in a premenopausal patient in the ovary that is less than 5 centimeters, it's considered normal. By simple, I mean it's fluid signal, thin-walled, and there are no enhancing solid components or septations. Dominant follicles can have a cumulus oophoris due to cells around a developing oocyte. This is not to be confused with a septation. Then ovulation occurs and you get a corpus luteum cyst that involutes, and it can look like this with somewhat irregular, thick walls that often enhance very avidly, like this. So this is a corpus luteum cyst, again, normal. You can also get some hemorrhage within a corpus luteum, a so-called hemorrhagic cyst, also physiologic. These are temporary and should disappear at the next cycle. Let's move on to some key principles that you need to know before looking at pathology on pelvic MRI. Some of this was covered in the body MRI video, but we'll focus on the most important stuff for pelvic MRI. All of this will be reinforced in the MRI cases as part of this course. Of course, simple fluid like the urine here in the bladder is going to be very hyperintense on T2 weighted imaging and hypointense on T1 weighted imaging. A lot of pathology that we're going to be looking for often has high fluid content like malignancies, cystic adnexal masses, etc. So they're going to be relatively T2 hyperintense, especially compared to the relatively dark organs, and relatively T1 hypointense. But there are many tissues that do not behave this way, and we need to be able to characterize those tissues when we see them. So we need to know the things that are T1 hyperintense, like fat, certain types of blood, and mucin, and things that are T2 dark. Most importantly for pelvic MRI, fibrotic tissue, and chronic blood products. Since a common indication for pelvic MRI is tumor staging, we'll briefly touch on what most malignant tissue looks like and the basic principle behind all pelvic MRI tumor staging. Okay, so let's talk about these tissues. First, fat. So identifying the presence of fat in a lesion is very important in Gyne MRI because it completely changes the differential. And we can use our T1 weighted sequences to identify fat. So bulk fat refers to tissue that is mostly composed of fat, like your subcutaneous fat, for example. This is going to be hyperintense on T1 and suppress on fat-saturated images. Notice that on in and out of phase images, bulk fat is hyperintense on both. There's often India ink artifacts surrounding the bulk fat on out of phase images. For example, in this case here, we have bilateral adnexal masses that are T1 hyperintense. They suppress on the fat-saturated images, and they remain hyperintense on the out of phase images as well. These are bulk fat containing adnexal masses, which is essentially diagnostic for this being a dermoid cyst or these being dermoid cysts. These are benign. Intravoxel fat, on the other hand, refers to tissue with both fat and water protons in each voxel. So intravoxel fat will be higher signal on the in-phase image and lower signal on the out-of-phase acquisition. We talked about intravoxel fat in more detail when we talked about fatty liver in the body MRI video. Modern MRI protocols make it very easy to identify fat in lesions very quickly. So look at this T1 fat only image here, and you can use it to screen for obvious fat content. And here you can clearly see that these are bilateral fat containing adnexal masses. And the fat only image will show both intravoxel fat and bulk fat. Okay, moving along to blood. So the appearance of blood, as you know, on MRI depends on the age of the blood, i.e. acute, early subacute, late subacute, chronic. But for body imaging for now, just know that subacute hemorrhage is T1 hyperintense. So it really stands out on the T1 fat saturated image as bright. So you can see that the bright hemorrhage here, for example, is standing out on the dark background of the fat-saturated T1 weighted image. So remember that hemorrhagic cysts are physiologic. So when a corpus luteum cyst ruptures, there can be hemorrhage within, but this is temporary and it disappears by the next cycle or so. Endometriomas, on the other hand, have recurrent hemorrhage within. So you have a combination of different ages of blood, with more subacute hemorrhage due to recurrent hemorrhage that is much more T1 hyperintense than a hemorrhagic cyst. They are also much more viscous with different ages of blood, including chronic blood products within, resulting in what is called T2 shading. So T2 shading in a T1 hyperintense lesion refers to a decrease in T2 weighted signal. For example, in this T1 hyperintense adnexal lesion here, notice that on the T2 weighted image, it is quite hypointense, so there's T2 shading here. It's much more hypointense than you would expect for a cystic lesion. The pattern of shading is variable. Classically, it was described as a gradient of T2 signal with layering dependent on hypointensity, like this image here. But it can also be more homogeneously T2 hypointense, like it is here on this image on the left. Next, mucin. So mucin has a variable signal depending on its composition. This is important in Gyne MRI, of course, because there are mucinous tumors that occur in the pelvis. Mucin can be more fluid-like, so low T1 signal or T1 hypointense and hyperintense on T2 weighted images, closer to simple cystic fluid. But in thicker mucin, certain macromolecules within make it more T1 hyperintense. We'll see examples of this later, but mucinous ovarian neoplasms are often multiloculated, like this lesion here. This is the classic appearance of a mucinous neoplasm on T1 weighted imaging, with different loculated areas of the cystic lesion containing variable signal due to differences in mucin composition of each. So the thicker mucin is T1 or more T1 hyperintense. This appearance is what is called the stained glass appearance. Next, fibrotic tissues. So fibrotic tissues are very dark on T2 weighted imaging. So they're usually as dark or darker than muscle. This is because there isn't much water in densely packed fibrosis. They generally also show slow progressive enhancement. Identifying fibrotic tissue is very important in pelvic MRI. So there are benign, solid ovarian masses that can mimic malignancy like fibromas. So this is actually an example of an ovarian fibroma on T2 weighted imaging. Also, when restaging treated malignancies, for example, after chemotherapy and radiation, post-treatment fibrosis will also look very T2 hypointense, contrary to viable tumor. This brings us to our last very important principle, the appearance of most malignancies on MRI, and the basic principle behind local staging of certain malignancies. So malignant tissue in the pelvis is often mildly T2 hyperintense. So here is an example of a normal uterus and cervix. Notice that again, the cervix is pretty dark here on T2 weighted images. This here on the right is a very advanced case of cervical cancer. All of this mildly T2 hyperintense tissue here is all malignancy. This is involving the cervix, or replacing the signal that we see in the cervix here, involving the lower uterine segment and extending down the anterior vagina here as well. So train your eye to recognize this mild T2 hyperintensity or intermediate T2 signal, also referred to as evil gray. Again, compare the normal vaginal tissue that's T2 hypointense with this tumor that is extending down the vagina here on this image on the right. Solid malignant tissue often also restricts diffusion, which is also very important. So two things to remember here. Many malignancies on T2 weighted imaging appear with this evil gray / mild T2 hyperintensity, and they often restrict diffusion. So this stands out on the background of relatively T2 hypointense organs like the cervix, rectum, vagina, bladder wall, etc. So knowing this, we can locally stage tumors by identifying which structures are involved by the intermediate T2 signal / diffusion restricting tumor. And in our course, we will go through examples of endometrial and cervical cancer and teach you how to stage these tumors and how that directly affects how the patient's cancer is treated. Okay, so that's it for the introductory portion of this course. Next, apply what you've learned by taking the MRI pelvis cases in our Gyne MRI course, which includes the most important pathologies that you need to know, walkthroughs of imaging findings, and everything you need to know about each case. This covers adnexal masses, staging endometrial and cervical cancers, uterine anomalies, and some miscellaneous, more challenging and interesting cases.